Hello, everyone, and welcome to the PT on Ice Daily Show. My name is Christina Prevett. I am one of the division leads. And at the time of this recording, which is July 15th, it is my birthday. And so, as a tribute to getting older and being an old person in training, I want to talk about the influence of working with older adults on our experience of aging. There was a new study that was just published that was speaking to the fact that if you work more closely with a geriatric clientele, you actually exhibit more ageism than somebody else. And the way that they looked at this was using the term that we talk about in our older adult courses, which is what comes to mind when you think of the word old. What they found was that healthcare providers working in the geriatric space listed more. Thank you, Lisa, for the happy birthday wish. They listed more of these negative age stereotypes around aging. This is really interesting, right? Because for many of us as geriatric clinicians, we are in this space. You are interacting with our courses because you love working with an older adult population. So why might this make us skew more negatively to older adults? I want to talk then about how this influences the healthcare system as a whole, and then really loop this around to a patient that I just had this past week, where I feel like she really, truly, unfortunately, showed all of the reasons how this ageism really affects care for the older adult. If we are to step back and zoom out, and especially for those who are not working in outpatient, but are working in inpatient rehab, acute care, skilled nursing facilities, long term care, home health, all of these areas of practice that tend to have a very high density of our caseload being with older adults. We are seeing people, especially in higher levels of institutionalization, in their most vulnerable moments, right? We are seeing our older adults who are struggling with frailty. They are struggling with weakness. They are struggling with comorbidity. They do have a lot of aches and pains. They are struggling with mobility. That mobility is hitting a tipping point where now they need help with activities of daily living. And that becomes our world day in and day out. And we are in such a wonderful, privileged place to try and help our older adults gain function. But we are seeing people towards the end of their lifespan in those vulnerable moments. They've interacted with healthcare for a really long time, and they can have a really negative slant about their trajectory for recovery. We are seeing people in those settings in their most vulnerable moments because that is the patient population that those healthcare institutions are established for. If we think about our aging trajectory, it is so heterogeneous, right? A 50-year-old can be still working, still running marathons, having no comorbidities, very active. We can also have a 50-year-old who is struggling with mobility, has had chronic illness for a long time, has not been able to maintain their work status, has had to retire early. And these two people, the 50-year-old who had to retire early with a complex medical condition, is more likely to be seen in our institutions than the really active 50-year-old. So I absolutely understand where this ageism is coming from, because in our world where we are seeing older adults, we are seeing the most vulnerable. When we look at our aging distribution and we look at the distribution of function and comorbidity and capacity and feelings of joy and purpose, we tend to see the people on the lower end of the function spectrum. What we can sometimes forget, and what is very easy for us to not really think about, is that there is a 75% curve that is not seeing us because they do not need our help because they are traveling in Europe over the summer, or they are in Ontario. We see so many snowbirds who go down to the southern US and they're hanging out there for the winter. And so with our healthcare, what we have to think about is we have to sometimes reflect that our patient population is not representing all older adults at a specific age. It is representing the most vulnerable older adults. Let me do another example. I have a high percentage of patients who I would consider masters athletes. They never consider themselves masters athletes, but I do. And I see quite a few pickleballers. I had a client who broke her wrist playing pickleball, and her orthopedic surgeon says, "Oh my gosh, I hate seeing you older adults coming. I just wish that all of my clients would stop playing pickleball." One, this is ageist in and of itself, right? Because if we see how many youth athletes break their bones playing contact sports, it's a pretty high percentage as well. But two, this physician has said pickleball leads to fractures because their job is to set bones and to have surgeries for people who have complicated fractures, right? So they may be seeing the 1% of the pickleball population over 65 that has a fracture, but it's making up 30% of their patient population. That doesn't mean that it is hugely common that our pickleballers are fracturing. It's that your job is to help them when they do. And so it can very easily slant us to this selection bias that pickleball causes a high amount of fractures. And so we have to be very, very careful to sometimes zoom out and reflect that our environment is going to invite a specific patient population in aging that is going to skew our perception unless we are very clear that it is this way for a specific reason, right? Like if you're working in long-term care, there are specific criterion that means that they have to be more vulnerable in order to see you in practice. So the individuals who are not as vulnerable are not going to be able to be on your caseload because they are going to be deemed too fit and healthy to be transferred into your care. And so that when we are so busy with productivity standards and trying to get home for family obligations, reflective practice is really difficult. And it is really easy for us to end up skewing this way unintentionally. This is a problem for healthcare at large. And there are four very big areas where ageism has very real consequences for our older adults. And so the first one is dismissal of symptoms and misdiagnoses because of age, right? We all know the stories. People are coming in with painful limbs and they're like, well, you are 60, there is wear and tear there. And they're often written off as things that are inevitable consequences of getting older. And they don't see that, well, yes, age is a very important factor to the distribution or the the development of things like arthritis and cardiovascular disease and almost every other chronic disease we know. When it hits the tipping point that their symptom threshold is starting to impact their ability to move around their environment, their quality of life, their ability to engage in things that they enjoy, just because it is a part of the aging process does not mean that we do not treat it. Another area where there is a dismissal of symptoms or even just a failure to interact with these symptoms is in mental health, right? We have this perception, this stereotype that as we get older, we become grumpy old men and women. And the true reality is that the highest incidence of mental health disorders is between like 35 and 45. So I'm like right in the key decade, right? Where we have older adults who, for example, with my dad lost his wife, his brother, his mom, his best friend from school, and one other friend all in a 3-year period. And he feels like he hasn't even been able to get his head above water because he has just experienced so much loss. And it was the funeral home that called and checked in to make sure that he was okay. And he's never been asked about his mental health or his grief or anything like that around when he's seeing his physicians. And his physicians have been his family doctor for like 30 years and was my mom's family doctor for 30 years. And so we often think that being miserable, being anxious, being depressed are normal parts of aging, or instead of giving conservative management, they are given medications that have very real side effects for our older adults. For example, like anxiolytics and antipsychotics, or anxiolytics, antidepressants, and sleep medications can lead to constipations, which have its own risk profile, for example, with our older adults. And so this ageism is it's really prevalent. The second area where ageism shows itself is in patronizing communication, often called elder speak, where, especially in hospital settings, people are like, "Oh, hi, sweetie. Hi, honey bun." Like, instead of giving the respect that our older adults deserve. And it's even harder for them because they're being infantilized too in a time where they are experiencing their most vulnerable moments. Another way that patronizing communication can happen is when the person is there, but the immediate response of the healthcare provider is to talk directly to the family instead of the person who is sick. This is making an indirect assumption that the person does not have the cognitive capacity or space to make their own decisions as an independent and autonomous older adult. And so there is nothing that drives me crazy more than, honestly, even the term LOL, my little old ladies, like, that is meant to be endearing, but in some cases it can be kind of patronizing. And so we have to be very careful with our language and understand where we can be unintentionally um, infantilizing in our language. The third area where ageism really impacts our healthcare is in the undertreatment and rationing of care. Now, this is really difficult, right? Because as individuals get older, the severity and the willingness of many of our patients to go to extremes for life sparing and life preservation starts to change and shift. But what we see is that, for example, somebody who is really healthy in their 80s who really should get a hip replacement, they're hesitating doing it because they're 80 years old, right? But not looking at the fact that they are really fit, they are really active, they're a caregiver to their spouse. Like, there is a lot of reasons why they should be eligible for this surgery, or this should be something that is considered, but instead they're deemed too old or not prioritized when it comes to surgical management. The other area here, and if anyone has taken older adult level 1, our week 8 speaks to this, is that often our older adults are assumed that they are set in their ways, and preventative care or health promotion is often not prioritized, right? When it comes to nutrition counseling, sleep hygiene counseling, working on trying to have conversations around exercise engagement, vaccine for like COVID and the flu, all of these things. Sometimes these conversations are more likely to happen with our younger patients than our older patients. And what we talk about in the course is that we kind of can make this assumption that our older adults are set in their ways. And when they're set in their ways, that there's no way that they're going to want to do that. Now, don't get me wrong. I'm going to have some clients that absolutely do not want to hear me. I have a client, he's in his late 60s, and he has a couple of glasses of alcohol before he goes to sleep, but it's making him get up and it's exacerbating some of his stuff. And I was like, hey, like, why don't we think about like easing off the booze, or making the booze earlier? And he turns to his wife and he goes, I need a new physiotherapist. And so sometimes it hits well and sometimes it doesn't. But the whole idea is that we want to open up the conversation and not go in with a preconceived notion that our older adults are not willing or are wanting that preventative care lens. And then the last one is around systemic and institutionalized issues. And this is kind of administrative, and it can show up as ageism, but it really is speaking to a really big problem in healthcare in general, is that we do not have enough geriatricians. Our clients so often fall through the cracks because of the silos of expertise that are happening within the healthcare system. And when we think about our geriatricians, they do an incredible job of trying to bring all these comorbidities together. But they're de-incentivized because guess what? Guess who does not get paid really well? Geriatricians. And so when we think about our geriatric units and cost and spending, our geriatric units often don't get paid well. Our docs who want to focus in geriatric care do not get paid as well as physicians in other areas of medicine. And so what happens is the cardiologist makes one recommendation, but it makes them feel really crummy. And then us in rehab are responding to this change in function, but we can't get a hold of the cardiologist. We have to go to the family doc, and the family doc forgets to send the letter to the cardiologist, and then things fall through the cracks. And now all of a sudden, our clients are struggling for months trying to figure out why they feel so crummy. And then they say that it's because you're older. Let's kind of bring this into a case study really quickly around how this showed up for a patient of mine. I am seeing someone right now who is 75 years old for fecal impaction, rectal prolapse, constipation, and she came in to see me. She's 75 years old and she hadn't pooped in a month. She had been to the emergency room 18 times. And she was told by some providers, well, this isn't a place to just sleep. Just take laxatives. You are older now. You're not going to poop as often, and has received so much dismissive care in emergency medicine. When she goes to her family doctor, again, she's prescribed laxatives or enemas. She has gone to a gastroenterologist who was able to give her a diagnosis of rectal prolapse, which means that she has a kinking and an obstruction potentially of her rectum that is making it more difficult for her to lose and evacuate stool. She has had to stop working because of this condition. She has lost 25 pounds because she cannot eat because of rectal bulk. Enemas have not worked. And she keeps getting tossed to all these different areas. Family medicine or emergency passes back to family medicine. Family medicine has gone to gastro. Gastro says your rectal prolapse isn't significant enough. I've seen worse. You're 75. Just take laxatives. The laxatives aren't working. She is now at risk for fecal impaction and a bowel obstruction. Like, she is a ticking time bomb for a perforation. And she is just getting segmented care. She is now traumatized. She came into my office in tears, trying to figure out what's going to happen. All of her muscles are now tense and tight. She is guarded. She is afraid of me because she has not been given the time. She feels like nobody is listening to her. Everybody is dismissing her. She's like, if it was just laxatives, don't you think that I would have figured that out by now? Now she's in like a very guarded nervous system response, and she is falling through the cracks. And I just see that she is this person that she's going to be at home and her bowel's going to perforate. She's going to need an EMS call. She's going to go into the emergency room. And if something bad happens, they're like, oh, I wish I would have caught it earlier. When she has been screaming to get somebody to pay attention to her. And so when I saw her, I had things within my lens, but then immediately I'm responding to gastroenterology. I'm responding to her family doc, being like, I am really concerned about this. Like, somebody who is losing 25 pounds at the age of 75, who did not have 25 pounds to lose, like that frailty, that sarcopenia, that disengagement with life. She's not going out into the community. She was working part-time. She's not working anymore. Like, she is in such a high risk. And because she is not in emergency right this second, people are passing the buck. She's being told that, your bowels are slower because you're 75. And it was just such a perfect example of how our system is just trying to pass the responsibility on to the next provider, how the segmented care is making this client fall through the cracks, and how the ageist sentiment of the providers is making her feel like her life doesn't matter. in her issues don't matter and that they just don't care. And I am not in the world of their brains, right? So I do not know the context. All I know is right now the output is that my client is having a really tough time. All right. I hope you all found this helpful. Sorry, I was a little bit more long winded, but I do think it is a really important conversation for us to be chatting about. If you have any of your own stories, I would love to hear them. But definitely something where the best thing that we can do is reflect on our own practice and think about the way that our colleagues are talking about older adults when we are in peer to peer communication. I hope you all have a wonderful rest of your week. We are around some of the smoke from the fire, so hopefully everybody is staying safe, including many of our older adults who might struggle with throat or lung irritation from the air quality. Have a wonderful week, everyone, and I will see you next time.